Assalamualaikum friends, I'm here OMAMA SHAH, and today is the last video of the lecture diuretics, and that is potassium sparing diuretics. So first we will be talking about its mechanism of action. Alongside we will discuss therapeutic uses, adverse effect, and obviously the drugs should also be discussed. Okay, so first and the most point is that why it's called as the potassium sparing diuretics. So they're called as the potassium sparing diuretics because they prevent the excretion of potassium in the urine, right? So if they're going to prevent the loss of potassium, you can directly say the potassium sparing diuretics can treat hypokalemia. In hypokalemia there is low level of potassium in the blood, right? So if there is low level of potassium in blood and you're going to give the patient you can also give potassium supplementation, but in case if the patient has high BP, right, and you're going to give other drugs like thiazides and loop diuretics. So thiazide and loop diuretics, they basically lost the potassium. So in thiazide and loop diuretics there is loss of potassium. So in order to prevent that loss of potassium in a patient in which there is already a hypokalemic condition, so you're going to give the potassium sparing diuretics alongside the thiazides and loop diuretics, right? Okay, so we will start from its mechanism of action. This is the distal tubule or of the nephron, right? This here you can see is the nephron. This is the proximal tubule, this is the loop of Henle, and this is the distal tubule. This is the early portion and this is the late portion or distal portion. So the potassium sparing diuretics basically act on this portion, means the distal portion of the distal convoluted tubule and the collecting duct. And as I told you earlier that the potassium sparing diuretics prevent the loss of potassium, right? Now we are going to discuss the normal mechanism, what happens. Now here is the hormone aldosterone. You have already heard of its name, aldosterone. It absorbs the sodium and it excrete the potassium. I mean it leads to potassium loss, right? So there is aldosterone hormone. The aldosterone hormone binds with the mineralocorticoid receptor, and that receptor is present in the cytoplasm of the tubular cell. So once the aldosterone binds with the mineralocorticoid receptors, it forms a complex, hormone receptor complex. You can also call it as a mineralocorticoid receptor aldosterone complex, right? So once this complex is formed, it then enters into the nucleus, and in the nucleus it leads to the formation of aldosterone induced proteins. You may also call it as the AIP. Now what's the function of AIP? AIP basically inhibit the absorption of sodium and loss of potassium, right? So it's done. What I told you that AIP, what it do, so sorry, AIP, what it do, it absorb the sodium and it excrete the potassium, right? So you are not gonna confuse with that. Aldosterone induced protein is responsible to act in the same way. What's the function of aldosterone? The function of aldosterone is to absorb sodium and excrete potassium, right? So aldosterone induced protein absorb the sodium and excrete the potassium into the urine, alright? So this is the normal mechanism. Now what happens when we are going to give the person potassium sparing diuretics? The potassium sparing diuretics, specifically I will talk about spironolactone and eplerenone. They bind with the mineralocorticoid receptor, and they basically compete with the aldosterone. They're just like aldosterone, so they compete with the aldosterone, and just just blocking the site for aldosterone. So once the spironolactone and eplerenone binds with the complex with the mineralocorticoid receptor, it stops or it prevents the formation of aldosterone induced protein, or you may say AIP. The function of AIP was to absorb sodium. So if there is no synthesis of AIP, or there is no formation of AIP, there will be no absorption of sodium and there will be no loss of potassium. So if there is no loss of potassium, its function is done. What its function is to prevent the loss of potassium. Spironolactone and eplerenone prevents the loss of potassium. So here the drugs spironolactone and eplerenone, they basically compete with the aldosterone, bind with the mineralocorticoid receptors, thus inhibiting the formation of aldosterone induced protein, or you may say AIP. If there is no AIP, there will be no sodium absorption and potassium loss. Okay, that's done. Now we have amiloride and triametrine. These two drugs basically blocks the sodium channel. Alright, so this blocks the sodium channel. The sodium channel, what it do, it absorbs the sodium and excrete the potassium. So if the channel is directly blocked, there will be no absorption of sodium, there will be no loss of potassium, and it's done. The channels are on the epithelial cells, right? So that was all about its mechanism of action. Now we get the point that it prevents the loss of potassium. In a short form, it the potassium sparing diuretics prevents the loss of potassium into the urine, right? Okay, now how we are going to treat, means in which patients we are going to give the potassium sparing diuretics. First, we are going to give that to a patient having hyperaldosteronism, whether it is primary or it is secondary. Whenever there is excessive excretion of aldosterone, we call that hyperaldosteronism. When the count of aldosterone level is high, we call it hyperaldosteronism. Now hyperaldosteronism is of two types. It may be primary. The primary is called as the Cone syndrome, CONN, and syndrome is a collection of diseases, right? So it may cause primary syndrome, primary hyperaldosteronism, which also called as a Cone syndrome, and it may be secondary hyperaldosteronism. Now, what's a primary aldosteronism and what's the secondary hyperaldosteronism? In primary aldosteronism, there is high level of aldosterone. When there is high level of aldosterone, there will be excessive absorption of sodium. When there is excessive absorption of sodium, it will also lead to the absorption of water. It will lead to the increase in blood volume. It can increase blood pressure, right? So there will be increased blood pressure. So what will happen? There is increased blood pressure. If there is increased blood pressure is already increased, so blood volume is already increased. So there will be, if someone asks you what will be the renin consideration in primary hyperaldosteronism, remember, renin is secreted whenever there is low blood volume. Now here I talked about the blood volume is increased, so the renin level will be low, right? You have to keep it in mind. The renin level will be low. Now moving onward towards secondary hyperaldosteronism. In secondary hyperaldosteronism, in the primary hyperaldosteronism is basically maybe caused by a tumor which lead to excessive excretion of aldosterone, right? But what happens in secondary hyperaldosteronism? The tumor is not involved, rather their secondary cause. The secondary cause may be, for example, renal stenosis. So what happens in renal stenosis? In renal stenosis, the blood vessel is narrowed. So the blood vessel is narrowed, the BP is normal, okay. Now the perfusion to the kidney is low, or you may say less. So if there is low perfusion to the kidney will detect the blood pressure is low, so they will excrete high aldosterone and high renin. There will be high renin and high aldosterone secretion, right? So because the kidney basically think that the BP is high, the BP is low, but the BP isn't low. There is hypoperfusion because of renal stenosis, and in secondary hyperaldosteronism, the other causes may be if there is congestive heart failure. So in congestive heart failure, the pumping ability of the heart is diminished, not that much proper. In cirrhosis, the scarring of the liver, and in nephrotic syndrome. So these all are the causes which can lead to secondary hyperaldosteronism. Now I think I talked about in the before that they are given in combination with the other diuretics, means as the other diuretics, for example thiazide diuretics and loop diuretics. They basically in these diuretics there is loss of potassium. So in order to prevent that loss of potassium in a hypokalemic patient, the potassium sparing diuretics are given, right? And you can also give thiazide and loop diuretics along with the potassium supplementation in order to prevent the potassium loss, right? Not prevent, but in order to increase or in order to make the potassium level normal. Okay. Now what will be the adverse effects? For example, if the person already has normal level of potassium and you're going to give the person potassium sparing diuretics, so it will lead to hyperkalemia because it prevents the loss of potassium. It can also cause drowsiness, GI disturbance, which may be nausea, vomiting, decreased libido, which is anti-androgenic effect, gynecomastia, in which male excrete milk from the breast, and menstrual disturbance. So that was all from my side. Hope you all get the point. Allah Hafiz for now.